Now coming to metastasis in the abdomen, two important sites are the liver as well as the peritoneum. So in this patient, you have a Linitis plastica type of tumor, small in size, diffuse disease, extensive ascites both in the supramesocholic and in the inframesocholic compartments. Also notice the presence of fluid in the lesser sac. So whenever you have presence of fluid in the lesser sac and greater sac, always suspect malignancy as the cause as compared to tuberculosis or other causes. And you also look at omental thickening, which is a very easy to look at and easy to document at peritoneal spread of disease in gastric cancers. Again, presence of lymph nodes, especially look them at in the venous phase, where you find that there are small subtle enhancing lesions in the liver. And also you have bulky lymph nodes in the para-aortic and aortic caval regions displacing the IVC in this particular patient with two different patients with gastric cancer. Now, MR, you don't do it as a routine to detect or stage, but in certain special instances, you can do, but you can detect gastric cancer as well. As an important sequence is called as a diffusion-weighted imaging, where you find that there is this bright area of restricted diffusion in the stomach here. And this patient also has got a large bulky lymph nodal disease in the peripancreatic region and the portahepatitis causing obstructive jaundice, for which reason an MR was done in the first instance. Though literature says that MR is good for T characterization as well, but we don't do it as often. Post-gastrectomy, again with obstructive jaundice, you find the remnant stomach here, a large bulky recurrent disease with nodes causing obstruction of the biliary tree with intrahepatic biliary dilatation. Also note these small metastases. MR is very good for picking up metastases, especially when you do a contrast-enhanced triple phase study. Now coming to PET-CT, which we perform very routinely, but no major international societies or guidelines advocate it as the first instance. It's very important in N and M staging. A standardized uptake value more than 2.8 is often taken as the cutoff for benign versus malignant. Usually perform an FDG-PET, but you have a new marker now, which is available here as well, Gallium FAPI scan, which has been found to be better than an FDG-PET, especially for mucinous and signet-ring cancers or poorly differentiated cancers. So one example of where this would be useful is in detecting metastasis here. You have a large bulky tumor showing uptake on the PET-CT. There is a fusion image. Also note the dirty greater omentum here showing these multiple nodules showing faint areas of uptake in the greater omentum. This is a pre-treatment study showing this bulky large tumor showing uptake in the gastric along the lesser curvature. And after neoadjuvant chemotherapy, this shows that there is significant decrease in the size of the tumor as well as the activity, suggesting that there is a significant response to treatment, and this patient went on for surgery later on. Now, FDG-PET, as I've said, that it shows low or no uptake in mucinous tumors, clear cell tumors, or signet cell tumors. So this is one example where there is thickening of stomach in the gastric antrum, no uptake or not much uptake in the whole body image, what you see in here. So in that situation, Gallium FAPI would be of benefit. This shows that there is increased uptake in the gastric tumor here, shown very well here, with no extra gastric disease in the abdomen or elsewhere in the body. So FAPI is a fibroblast activated protein inhibitor which concentrates in tumor microenvironment, unlike FDG-PET, which uptake happens in the cells of the tumor. So in conclusion, I would say that CT would be the mainstay of disease staging as well as surveillance, especially for T2 to T4 diseases, endoscopic ultrasound in early disease, especially when you are planning for endoscopic submucosal resection. PET-CT definitely would play a role in pre and post therapy evaluation. Thanks to Dr. Vijay Bada and the team for having me here. Thank you so much.